Hello and welcome to a special interview for The Wire supported by Glenlivet Books. Now that the daily tally of COVID cases has started to decline, and now that the ICMR second serological survey has suggested that perhaps as many as 14% of the country's population is infected, including undetected cases, I'm going to put these issues to one of the most highly regarded epidemiologists in the country and ask him, what does he believe is the big COVID picture facing India today? He is, of course, the former principal of Christian Medical College in Vellore and the chairman of the Scientific Advisory Committee of the National Institute of Epidemiology, Jayaprakash Muliyil. Professor Muliyil, several newspapers say that the 7-day rolling average of daily cases has been steadily declining for 11 straight days. Secondly, all the reports suggest that the active cases have also been under 10 lakh for 10 straight days, and the trajectory once again is downward. And thirdly, two separate institutes say that the R factor has fallen below 0. How do you interpret this data?
Well, first of all, we should recognize the fact that the data primarily represent what is happening in the cities of India. That's where this is generated. So the rural area really doesn't come in here at all. And when you look at it steadily for the last 1 week, thing is falling. It's quite exciting and probably it means well. So I'm going to be optimistic, but I'm going to wait for a few more days before I make up my mind. Now, the R effective that you referred to has fallen below 1, according to some calculation. And these calculations has a methodology and there are problems with it, but whatever it is, it means that R effective has come down. We want it to reach 1. 1 is a point at which the disease becomes endemic, quiet, and won't trouble us anymore.
Can I point out, sir, that both the University of Chicago and the Institute of Mathematical Sciences in Chennai say that it's actually fallen below 1. They say it's around 0.91, 0.93.
Good. That is a very, very, very exciting finding. Well, we will watch how, because this is based on the numbers reported by us, right? So there are problems with the number that we report, and I hope that is not affecting the calculation. Okay. But I am optimistic.
Now, as you said, you're optimistic. You think this news that the decline is starting is exciting. It means well, but you're still cautious. You want to wait a few more days before you give a final opinion. Let me ask you this. To what extent is your doubt or your concern propelled by the fact that the vast majority of tests are antigen tests? And as you know, antigen tests can produce up to 50% false negatives. Are you therefore concerned that this decline that we're seeing in cases for the last 11 days is not perhaps reality, but possibly a reflection of false or poor testing?
There is a reason why you would do this testing. Some is to diagnose the disease in symptomatic. Some is to identify patients who are subclinical or asymptomatic to see if they are virus. When you use it for the first purpose, RT-PCR seems okay. But the problem has been when people use it on a random basis, what happened? Will you miss out cases? Yes. But the ones you miss out are not likely to be infectious. So from that point of view, it will not affect either disease transmission or the count. So I'm not concerned.
You said something very important, and I'm repeating it for the audience, that even when you do antigen testing, the ones you miss out are not likely to be infectious, so it doesn't matter. Is that right?
Correct.
So in other words,
correct. RT-PCR tend to have a lot of false positive when you are using the gold standard as culture.
So if the ones you miss out by antigen testing are not likely to be infectious, then you're saying you're reasonably confident that the decline in cases that we've seen for the last 11 days is a genuine decline. It's not a result of faulty or poor testing.
Well, this particular factor doesn't explain the whole fall. Is there something else we need to see? Okay, there are many things can go wrong in India. So that is why I'm cautious, not because of the antigen testing. That will not be a reason in my mind.
Okay, that's very clear. Now, in an article that they wrote for the Hindu yesterday, Tuesday, T. Jacob John and M.S. Seshadri claim that India has already peaked and is declining. They say that at the peak, India was growing by some 642,000 cases a week. Now it's growing by just 577,000 cases per week. Now, I know you've read the article, so let me ask you, do you agree with their conclusion that India has peaked and is now slowly but steadily declining?
I agree about the urban India, because that particular number that they used reflects more of urban India than total India. And I think from that point of view, if you were to say they refer to the cities of India, yes, I think there is a decline. There are several ways you approach this modeling, and they use one particular technique. But also the paper very confidently tells you about how these two gentlemen are comfortable that the infection gives you long-lasting immunity. Okay, that is also part of the message they give us. So whether this will take that long is a different issue, because the climb, because of the inflationary way this goes up, it goes very fast, agreed. But once it drops because they run out of steam. What is the steam they require? Susceptible population.
Okay.
When the number of susceptible population dropping, then I think the drop will be faster than they anticipated.
So you're saying two important things. With regard to the claim made by T. Jacob John and Seshadri that India has peaked and is now slowly but steadily declining, you're saying this is probably true of urban India, but you have your doubts about rural India. And the second thing you're saying is that you would like to see a sharper, more cliff-like drop rather than a gradual slide. At the moment, you're seeing a gradual slide, which also is reason why you're cautious.
Well, I don't think it will take as long as they are projected, but we'll see. I mean, these are all projections. I have my way of thinking. I think the fall will be more rapid, but I may be wrong.
Now, Dr. Muliyil, there are two discordant notes, and I'd like to put both of them to you one by one. The first is that whilst the daily number of cases is declining and has been declining for some 11 days, the daily number of deaths is actually, when you compute it on a weekly average basis, increasing. As a result, deaths per million in September alone have increased by some 42%, from 50 per million to 71 per million. How do you account for that?
The occurrence of new case and the deaths are not correlated in time. They are sequential. So whatever happens for the case reduction is followed by deaths after a week. So you need to see what happens one more later. Remember, before that it was climbing, and those high number of deaths are the remaining memories of that climb, because the incidence of disease follows disease and the disease follows death. So there is a time lag, and that is the time lag you are referring to, and this is expected.
So you're saying that in a week or probably 2 weeks' time, the number of deaths will start declining, just as already the number of cases has started declining.
Correct. You got the point.
The second discordant note comes, in fact, from your own state, Kerala. 2 months ago, everyone looked upon Kerala as a shining example of India's success. Today, I notice that, in fact, you have cases increasing at over 7,000 a day. The positivity rate has crossed 13%. The state government itself accepts that 95% of the cases are actually from local transmission. And now, the Chief Minister had an all-party meeting yesterday to see whether a second lockdown is necessary. He's not brought one about immediately, but he's kept open the possibility of another lockdown, say 2 weeks down the road. What's gone wrong in Kerala?
Well, I remember giving a talk to a group of Keralites, public health specialists, long ago, where I congratulated them for the good work. But at the same time, I warned them, but it is possible that the virus may return. And I warned them, that is not a failure on your part. It is purely the nature of the virus, so infectious. I think they are facing it well. Nothing unexpected about the rise in Kerala. And they are, even now, they seem to be doing a good job. The question comes up is whether lockdown will help. I don't know. The Kerala, they should take care of themselves. But in my opinion, the lockdown, they should reconsider before they embark on it, because that's an educated population. And remember, why we are worried about the disease is deaths. And deaths are primarily in above 60. And if Kerala can make sure the above 60 are protected till the vaccine arrives, I'm sure they can manage the virus very efficiently.
In fact, Professor Muliyil, the deaths in Kerala are the lowest of all the southern states. And therefore, in terms of death and managing death, Kerala is doing very well. But the important thing you said about the sudden resurgence in cases in Kerala is that that is part of the nature of the virus. You had predicted that, in fact, it could return, it has returned, and you're also saying it would be wrong to panic and go into a second lockdown. Let's then move at this point to a second issue of great concern. How many undetected cases do we have in India? Now, the first serological survey done by the ICMR, it was done in May and early June, suggested that for every reported case, there were possibly 82 to 130 undetected cases. The second serological survey done from mid-August to mid-September, and its results were released yesterday, Tuesday, suggests that for every reported case, there are only 26 to 32 unreported cases. There's a huge difference in the numbers between the two serological surveys. And many people see this huge difference and are perplexed. How would you explain this very, very significant difference?
There are exactly two reasons for it. Number one is something when you do a survey, we are exposed to what is called a sampling error. And precision of the estimate is affected by the sampling error. So the first survey, we lacked precision because the disease frequency was less than 1%. This time, the disease frequency is higher, so our precision is much better than last time. That's number one. The second thing, and this is more important, at that time, the testing in many of the villages had not reached at all. Here, if you don't test, there is no diagnosis made. The only way we get to call somebody COVID case is by doing a test showing that he has got the virus. It was not available in most places. So when you did this survey, we found that even those areas where there are no cases reported had serological positivity. So now I think the outreach or the services reaching out to the rural area have improved, and they are able to test people, and consequently the the equation chain. Now, if you look at Pondicherry survey, the multiplying factor was 26. Pondicherry is a place where there are a large number of hospitals, healthcare facilities. So that is the multiplier in Pondicherry. And in the second survey, this particular one is approaching that particular level of efficiency.
Okay.
But ideal condition should be much smaller, but that's all we can hope to have.
Now, the first serological survey suggested that if India has 6 million confirmed cases and the ratio remains the same, then the undetected cases would be somewhere between 490 million and 780 million. The second survey suggests that if India has 6 million confirmed cases and once again the ratio remains the same, the undetected cases will be somewhere between 156 million and 192 million. Let's discard the first survey completely. Do you accept that this range for the second survey is right, that the undetected cases as of today is somewhere between 150 and 200 million?
Well, I just don't remember calculating that, but the estimate is correct, what you are talking, that it ranges. In fact, they will be in the paper, it does not come out, give you the accurate. There is definitely a big amount of disease we don't see. It's like an iceberg, and that is submerged. So we keep looking at the little bit we see in terms of reported cases, but 26 times or 27 times more is hidden. And that's what makes it difficult to judge all this number game. And we have been into number game from the beginning, and we have to be cautious as we interpret it. So I would agree that the actual infected number is very large.
The actual infected number is very large. Now, these surveys that we are discussing have a huge set of implications for herd immunity. In that article that they wrote for the Hindu yesterday, Tuesday, T. Jacob John and Seshadri relied entirely on the first serological survey. Unfortunately for them, the details of the second serological survey had not come out. And on the basis of that first serological survey, they claimed that 35% of the Indian population was already infected. They also said that a second 35% would be infected over the next 6 months, by when 70% altogether would be infected, and they believed herd immunity at that point would have been achieved. Now, the second serological survey paints a completely different picture. According to the second survey, as of today, barely 13.9% of the population is infected. That's including the undetected cases. So, according to the second survey, herd immunity is still very far away. What's your feeling about this herd immunity issue?
Two things I need to mention. If you look at the survey and look at the stratification, rural, urban slum, urban non-slum, which has not been published, you'll find a 3 clear strata. The rural is the lowest, urban slum is the highest, and urban non-slum is somewhere in between. So urban area is much, much more infected than rural area. That is number one. Number two issue is that the herd immunity required depends on the density of the population. So villages, because the low density, will require a much lower herd immunity for the disease to come to manageable level. So, and urban area will require higher. So these things have not been considered. The problem of taking India as a whole and trying to find an average is always difficult for anything that you do.
So you're making a very important point. You're saying when you try and estimate at what percentage herd immunity will become effective, don't take India as a whole. It's a subcontinent. You have huge differences in density of population. Therefore, you should consider the issue of when herd immunity becomes effective in terms of regions, in terms of cities, in terms of villages, each taken separately. Is that right?
Absolutely.
Let me ask you one more question connected with this. I know we don't have a clear, precise number, and we in fact cannot have a clear, precise number of the number of people who are infected but undetected. But the second survey suggests it's somewhere between 150 and 200 million. Now, clearly, these are people who are asymptomatic, or if they have symptoms, they are so very mild, they don't care about them. The question is, how good or bad are these people at infecting others? How much of a danger are they to everyone else?
The question is whether these mildly symptomatic or asymptomatic, are they infectious? Yes, they are infectious. And in fact, this is the problem of controlling the disease. If you look after only symptomatic, you will only get a small percentage, but the disease is spread by the others too. Yeah.
But just a moment, didn't you earlier say when we were talking about antigen testing and the fact that antigen tests can sometimes show up to 50% false negatives, your words were at that point, it doesn't matter about the people you miss out, they are not likely to be infectious. Now you're saying the asymptomatic are infectious.
Correct. So we do testing for two situations. One, when you suspect the disease and you want to treat the person for symptoms. Second you do is asymptomatic. And what are the reasons for doing asymptomatic? I mean, people with no symptom, to find who has got the virus so you can isolate them. All I'm saying is, yeah, people with asymptomatic disease can be positive, but the antigen test is better technique of testing for them than the RT-PCR, because RT-PCR, once positive, tend to remain positive for a long time, unnecessarily calling somebody a danger to community, whereas it is not, because it is all viral particles which are non-infectious. So the point is that the whole strategy has been based on identify people who have the virus and isolate them.
Okay.
Identify the people with virus, isolate them. In that context, I suggested, please don't use the RT-PCR. You will be more efficient if you're in the antigen testing.
So just to clarify for the audience, because otherwise they may be confused by what seem like two contradictory answers, what you're saying is, in terms of testing, you have no problem with the antigen test, and there, even if you miss out on some, it doesn't matter, they won't be infectious. But nonetheless, when it comes to people who are asymptomatic but still positive, they are infectious. Now that I've repeated what you said, I have to also repeat my concern. This does sound to me, once again, Dr. Muliyil, like an answer that's contradicting itself. Because if it doesn't matter at the antigen testing level, because the people aren't infectious and therefore missing out on them isn't a problem, then those are the very people who are asymptomatic and are part of the serological number of 150, 200 million and infecting others. So isn't there a contradiction here, or am I simply failing to understand you?
It's okay. The confusion comes up this way. When you are in a mode of containment, you want to pick up everybody who's infectious and contain the disease. Now that time is gone. There is virus all over. How many people are going to isolate? Okay, so in that context, your strategy should change.
Okay.
Remember, this disease can be prevented if you take care of yourself.
Let's then at this point come to this issue, and it's a broader issue, whether the time has come to change strategy. Do you believe that now, when perhaps as many as 200 million people could have been infected in the country, roughly 13.9 or 14% of the population, we should focus much more clearly on protecting the elderly and those with comorbidity, and say to everyone else, wear a mask, maintain social distance, and get on with your lives. Should that be the new strategy?
I strongly agree with that. The point is this. The one good thing that is emerging is, whichever way you look at, the mortality seems to be lower than expected. Okay? To some extent, that is a good sign. And most people who face mortality are above the age of 60. So yes, we need to protect them. And more importantly, all these restrictions, if you don't want to get infected, if you wear a mask and take basic precaution, you are safe. Give that context and don't have to isolate people, quarantine them anymore. In fact, the quarantine is very wrong concept in today's India.
And you're also saying that the comparatively low mortality rate of India, particularly compared to Europe and America, is another reason why this new strategy that we're discussing makes sense. Is that right?
That's correct. And also make sure all the people who are admitted are only ones who need admission, who are sick, because our doctors are now become pretty good at looking after this patient, and mortality has really come down. And I don't think that whole strategy of actually stigmatizing the disease, so to speak, has to change. And also encourage people to know that once they are cured, they are actually no more a danger to society. In fact, they are immune for a long, long time.
Now, Professor Muliyil, in 3 weeks' time, India will celebrate Dussehra and shortly after that, Diwali. In the present circumstances, is there need for the government to take special precaution, issue special instructions so that these festivals don't become super spreaders, or are you not that concerned about it?
I am asking this question. Can the people take care of themselves? Yes. But the problem is, in festival mood, things go wrong. I think there should be continuous education to say crowding is going to be dangerous. Wearing a mask, even during the festival, is a safe method. And I think I can't support that huge crowds will form that will transmit the infection. And in the process, even elderly will get, or susceptibles who are likely to die will get infected. So I see some sort of a restriction is important. And I somehow feel that unfortunately in India, in many places, the ability to control themselves is lacking. And what happens is then government has to interfere. This clash between these two is not a healthy thing for the country.
But you are clearly saying, Professor Muliyil, that some sort of restrictions is necessary, primarily because left to themselves, people won't be disciplined and control themselves. Therefore, some sort of restriction at Dussehra and Diwali is necessary to avoid large crowds and to avoid infection spreading.
That's right.
Finally, by coming to the end of this interview, you are widely acknowledged as one of the foremost, if not the foremost, epidemiologists in the country. What is your view, what is your assessment of the way the government has handled the COVID crisis over the last 6 months?
Well, that's an essay question, but I will tell you, it is a difficult country to handle. And the people, varying amount of information, knowledge, ability. The one thing I think we did wrong was to impose this nationwide lockdown. It caused a whole lot of harm that was unfortunate. Now, we are struggling to get back into the normalcy, and it's been months and months. This was not anticipated. I wish we had anticipated. So a little later, we will be evaluating which was more harmful, the COVID itself, or was it the lockdown and the consequent problem because of that. But that is one issue. Otherwise, in terms of management of cases, testing around, all these things, the country has responded quite well. The only thing that I'm uncomfortable is there's a huge amount of state to state variability in terms of the manner in which patients with COVID and their relatives were cared for or looked after. And I wish that this particular angle was emphasized early enough.
I'm going to pick up on the very first part of your answer. The one thing we did wrong was the nationwide lockdown. You were absolutely crystal clear in saying that was a mistake. But the government insists repeatedly that the lockdown has helped curb the spread of the disease. That if there hadn't been a lockdown, the numbers would have been greater, the deaths would have been more. You're clearly disagreeing with that.
That's what I sounded like, right? That's what I meant to do.
So you
That's correct. I'm disagreeing.
So,
I'm disagreeing with that.
Sorry, could you repeat that again?
You said, am I disagreeing with the government claim? Yes, obviously I'm disagreeing. I always disagreed. I continue to disagree. That was not called for. There were certain restrictions we could have put, but still the mortality would not have changed. The same results would have come. We unnecessarily tortured our economy and made many people lose their livelihood.
That is a very, very strong criticism of the government, because the very key and the center point of their strategy handling the COVID crisis was the lockdown. And the Prime Minister repeatedly claims credit for this. You're saying that we unnecessarily tortured the economy and we unnecessarily cost people their livelihoods.
That's correct.
All right, you're very outspoken. In which case, one more question before I end. The head of the ICMR, Dr. Balram Bhargav, has said to the British paper, the Financial Times, on the 25th of September, that India has shown the world how to fight emerging diseases. I'll repeat that quotation. India has shown the world how to fight emerging diseases. Do you believe we've shown the world how to handle COVID?
Well, I think, I sincerely think he was referring to the way our system, our doctors, our hospitals, rose up to the occasion in a difficult situation and provided service and care. And he was representing that particular aspect of a battle. That's where the battle was, in the hospital, in the centers where they are looking after. And I think he probably was meant to tell the world that India has a whole. But I think I should also add probably that Indians are also very resilient, very tolerant. They suffered in silence and took it all. And that, I think, is a way India has always been, very patient. And any other country there have been, violence. We did it all very gently and nicely. And I think he was probably trying to explain it, in my opinion, because I don't think he meant anything else.
Well, you've given a very diplomatic answer, Professor Muliyil. I won't question you further, but I'll point out to the audience that you believe that Dr. Bhargav was talking about the response of nurses, doctors, healthcare staff, and hospitals in terms of caring for those who fell ill. And very pointedly, by not mentioning it, you haven't said that the strategy based upon the lockdown was the right one, or that it actually showed the world how to handle COVID. That you've left out. And I think those who are intelligent will not just read between the lines, but also realize why you've left it out and what precisely you're saying. Thank you very much for this interview. I'm extremely grateful. Take care, Professor Muliyil. Stay safe.
You too.